Many of us who work in the field are familiar with the STAR-D trial. It always amazed me that such a small percentage of patients actually responded during their first course of antidepressant treatment. I think it was only about a third or even less than a third. And would you expect that that is, at least in part, a consequence of the heterogeneity of the sample?
I think it is, yes. I think everybody was surprised about it, and more recently, over the last couple of years, some additional critics came out to say the response is even worse than it was originally published. So the good thing from study is that it was a bit of a wake-up call. Yeah? People thought this is just not a way we can move forward. Out of study came a number of, I would say, exploratory analysis which helped us to understand what actually happened there. And one of the studies I have in mind is that people with higher levels or atypical symptoms, for example, did not respond to SSRIs as well as people not with atypical symptoms. People with anxiety didn't respond as well as people who did not have anxiety. And this actually brings us to, I would say, for some reason, not frequently discussed disparity between how we identify patients with depression with our diagnostic instruments, these days the DSM-5 and ICD-11, and the instruments which we are using to show improvement of depression. And if you recall, DSM-5 criteria, for example, do not include anxiety, but of course anxiety is one of the major characteristics both in the Hamilton Depression Rating Scale as well as in the Montgomery-Åsberg scale. So we have anxiety in that context. On the other hand, the catalogs require or allow that patients with hypersomnia or people with increased appetite can be increased in their depression severity, whereas the Hamilton and the MADRS don't take those symptoms into account whatsoever. So if you have hypersomnia or weight gain, it doesn't add to your depression severity according to the Hamilton scale or the Montgomery-Åsberg scale. So there is this disconnect which is quite surprising because this is the way how depression trials have been done for the last 50 years or so. And it should be quite obvious to everybody that there is a problem there. And this disconnect, I think, can lead to a situation where you recruit patients based on a high Hamilton scale, which is then biased for people with more melancholic symptoms, and people with atypical symptoms are systematically excluded from these trials. And the way how basically the criteria according to the scales of the severity of depression would reflect the severity, because hypersomnia and increased appetite definitely add to the severity according to the DSM-5, for example, criteria. So there is this interesting disconnect, and I think we have to get to the ground of things just from a very, I would say, practical, operational perspective to keep that in mind and potentially rectify this.
So from a protocol design perspective, these might be things that investigators might consider as they're designing their new protocols. One other thing I wanted to ask you about is related to placebo response in depression. We know placebo response is high in this particular indication, and we're not comparing baseline to post-treatment. We're comparing post-treatment on active drug to post-treatment on placebo, and very often these conditions don't separate. What do you think is happening in placebo response, and how can that be mitigated in clinical trials?
Yeah, so I think there are several aspects to it which have to do with the placebo effect. I mean, there is neurobiologically, of course, this type of top-down regulation where with the expectation to get better, there's actually a change in the neurobiology. Your autonomic nervous system can get better. So I think that's something which has to be kept in mind. I think there's a general awareness that sites, when they are dealing with patients, shouldn't be overly empathetic, but more objective in the way how they treat patients. That's also fair and well and the way to do it. But I think one of the areas of importance is, as I said, depression in particularly gets better with time. And if you have differing neurobiological and clinical aspects of depression, you just have a variability in the natural cause, which basically means you mix a whole bunch of different people which you put into two different groups. So there's a huge variability just on the basis of the natural cause of the improvement, which then makes it very difficult to see an additional improvement with a medication. So I think, again, it comes down to the heterogeneity, to the variability in the clinical and neurobiological expression of the disorder, which makes it difficult to find a clear signal. If everybody would respond exactly the same, even if it would be a fairly large placebo response, it wouldn't matter, because you would clearly be able to see the difference between those treatment arms. I mean, even in clinical trials, we are far away from, let's say, a bottom effect. There are people at the end of the trial still have a Hamilton of whatever, 12, 14 points. So there is quite a bit of room for improvement even after they are treated. But I think it's really the heterogeneity which at the end of the day kills the statistics, the p-value of the differentiation. And I think this is another reason which helps to streamline and clinical trials and helps to see a clearer signal with better characterizing the subjects which you include into your trials.
What do you see as the future of clinical trials for depression?
No, that's a very interesting point. I mean, there is, it's a bit of a long-term perspective which I have. At this moment in time, of course, we are still characterizing, and this will go on for quite a while. And there was the RDoc initiative, of course, which tried to bring a little bit of biology into the clinic. But I think we have to put the RDoc from the head to its feet, if you want. So we have to start with the neurobiology to characterize patients, not with the clinical symptomatology. And the expression of a certain neurobiology can be very different. I mean, we know that from the area of, let's say, Parkinson's disease, for example. I worked quite a bit in Parkinson's disease during my career. It's fairly clear that one of the main neurobiological characterizations is a lack of dopamine. And of course, this has effects on the motor aspects of these patients. They have rigidity. They, of course, have just difficulties moving. They have bradykinesia, so slow movement. They may have tremor. They also have affective symptoms. They can have anxiety and they can have depression. So, which means that there is one fairly well-established neurobiological cause which has very different clinical expressions. And I think to just assume that a certain clinical expression is based to just one or few neurobiological reasons is probably an oversimplification. So I think in order to come to the ground of things, you probably should start with the neurobiology and then see what the changed neurobiology can actually do to the clinical expression. To characterize an improvement is then, of course, a challenge. Currently, we are using a fairly specific way of characterizing the improvement with a set of questions which are asked to patients, that you probably have to be more open-minded about what actually matters to the patient. And I'm always amazed that if you see a clinical trial which is successful, you always see potentially even a higher differentiation based on p-value with a very simple question: is the patient better or not? Basically a CGI, a clinical global impression thing. That is what matters for the patient. And I think that's what we have to keep in mind, that sometimes you can be maybe a little bit too over-specific with the way how we try to characterize the suffering of people.
So the patient input into deciding what's really important to improve is really important.
And I think that's a very important point to keep in mind. This, this is how psychotherapy works. Yeah, more often than not. Yeah, you basically ask, what is the first symptom? What is the first issue which we want to address? And then you go one after one. Yeah? And so we have this system to do everything at the same time in a kind of undefined way. And I think that's problematic.
One of the trends I've noticed is that there's a greater interest in achieving an antidepressant response earlier on. Years ago, we would wait 4 weeks, 6 weeks in order to determine if the patient would respond. Now, there seems to be a greater interest in looking at shorter response times. Do you also see that as kind of the wave of the future?
There is a good indication, actually, from a group in Germany, the Mainz group. They did studies 30 years back, starting in the 1990s, to say if you see an early improvement in the first 2 weeks of treatment, you have a very high chance of having a good outcome further down the line. If you don't see an improvement, it's much more difficult. So I think the early improvement is an important aspect of the long-term benefit. And if you think about the neurobiology, there's a lot of discussion, why wouldn't an SSRI or some mode of action which immediately leads to a change in reuptake of serotonin or norepinephrine, whatever it is, why doesn't this change lead to an immediate clinical improvement is, as far as I can see, is still an unanswered question. I think we just got used to the fact that we have to wait for a long time before we see an improvement. As I mentioned, I had an interest early on in these rapid-acting antidepressant modes of action. Sleep deprivation is really a great physiological example. It doesn't involve any psychopharmacological intervention, and you see a whole bunch of really interesting neurobiology which can actually help to identify a new treatment approach. And as I mentioned as well, glutamate played a huge role there, before the ketamine story broke loose. And so there's a bit of a consistency in this regard that for a rapid antidepressant effect, glutamate may play a role. However, again, this is probably not true for all patients with depression. It's true for a certain subset of people with depression, and you would have to identify which ones they are. And just going back to the research from sleep deprivation, people with atypical depression would not respond to sleep deprivation. I am not sure if anybody did a study with ketamine with atypical depression. This may not work as well if similar mechanisms play a role, but I'm not aware that anybody studied that. Whereas sleep deprivation typically works for people with melancholic depression, people who have hypersomnia, have early morning wakefulness anyway, and people who typically show high cortisol levels. So there's a fairly well-defined neurobiological basis for this rapid-acting intervention, and I assume this may also be the case for other rapid-acting interventions which are studied at this moment in time. So I think specificity, again, is of high importance in this regard.
Okay. And if you had one suggestion or a bit of advice to give to people who are studying in this field, what would it be?
Get out of your head if you want so. As I said before, depression, like many other psychiatric disorders, is not a pure brain disorder. It's a disorder of the whole body. There's much to learn about what happens in the brain when you look at the body, and there are these, of course, opportunities to change the body. We didn't talk about the gut-brain axis, of course, a big topic. You can change your diet, your bacteria in your gut, and your mood changes. That's something which Friedrich Nietzsche would have predicted, who saw a very close link between a good digestion and a good mood. So again, not a new thought, but to keep these bodily functions in place and put them into the context of your overall emotional well-being is something which I think will become more important in the future.
Wonderful. Well, thank you very much, Harald, for a wonderful conversation. And I hope to talk to you again.
I thank you very much for the opportunity. It was a lot of fun. Thank you.